Hello and welcome to the Neurocritical Care Society podcast. I'm your host, Nick Morris, and today I have a very special guest, Dr. Mona Kumar. Dr. Kumar is a full professor of neurology, neurosurgery, anesthesiology, and critical care, vice chair of quality for the Department of Neurology, director of the Neuro ICU at the Hospital of the University of Pennsylvania, departmental diversity search advisor, co-chair of the Interdepartmental Equity Committee, and past chair of the Penn Forum for Women Faculty. She served on the NCS Board of Directors and has previously served as the board liaison to the Inclusion in Neurocritical Care Committee and prior chair of the Women in Neurocritical Care Committee. She has been a lifelong proponent for advancing women's careers of all stripes and has been a huge influence and advocate for inclusion in neurocritical care. And that's what we're going to talk about today. Dr. Kumar, welcome to the podcast.
Thanks, Nick. It's really amazing to be here.
Well, thanks so much for taking out time from your day to do this. And you've taken out a lot of time from your life, really, to pursue this, what to me really seems like a calling in advancing diversity, equity, and inclusion, particularly within our field. Can you tell me, where did this come from? When did you get passionate about this?
So I think that I'm someone who's just been passionate about sort of this work for a long time. I mean, even before I came to medicine, I worked in homeless shelters, domestic violence shelters. I worked for at-risk youth around LGBTQ issues and housing insecurity, and so that's just sort of the person I want to be and think that I am. I will say that I think I got a little derailed when I got into medicine. Sort of felt like I needed to walk that very narrow path of academic medicine, and didn't really, I don't know, stay true to the person that I was. And I think that as I've advanced in my career, I felt a little more agency in defining my life for myself. I think it's sad that it took sort of getting to the rank of professor before I felt like I could do those things. But I would actually say that it was medical students who really sort of helped me pivot into the space. I had the great fortune of facilitating a doctoring course with first year med students, and we actually followed the cohort out to graduation. They graduated last year. And in sort of really helping them, I understand their own identities so that they could bring their best selves to being doctors. I realized I'd forgotten who I thought I was, and so it was because of that that I sought the position to be the chair of the Penn Forum for Women Faculty, and after that, it just sort of snowballed into opportunities to really just go where my passions truly lie.
Yeah, that's really cool. Can you tell me around what year did that happen where you started to take on these roles?
It really was like 2018, I think, before sort of George Floyd and Ahmaud Arbery and some of the kind of collective awareness as a society. So I think they graduated, I think it's almost a year or two now, and then we started the first. So yeah, somewhere in that like 2018 time point. And one of the things I think that really also kind of made me come to this, I think, is one part of my job that I really love is taking care of patients and speaking to them and their families. And it occurred to me one day that I feel more of a onus to take good care of patients when there's another person that I'm responsible to. So if there's someone at the bedside and I know that I'm going to talk to them the next day, I
Mm-hmm.
feel like I need to really be on top of it and know all the details and do all of those things. But then I realized, like, well, if you don't have the privilege or the luxury of having someone at bedside every day when the team comes, and the teams come some days first thing in the morning and sometimes later in the day, then you might not get that sort of um, that the onus from the team to serve you and your patient and your loved one that as well. And that really bothered me. And so I started to think about in my personal practice, how can I follow up with families, personally and directly even if they can't be at bedside. And so I started to adopt different practices and call family members either before rounds or after rounds. And I try to make sure that I speak to that person's designated, you know, care provider or, loved one directly myself. And then I sort of started thinking during COVID, like, could I actually study this? Because in the past, like, we don't really document a lot about whether we're talking to families and how we're talking to
Hmm.
families. But when COVID sort of provided an opportunity where no one could come in and we had to document everything, could we actually look at how much time the healthcare team spends with family members? And can we think about how many times we had a formal goals of care conversation and how many times were we reaching out and how long were those conversations? And there was some attempt in my mind to sort of answer this question that's sort of been burning for me personally. And so I'm still sort of in the midst of that project, and we're actually even using natural language processing to look at the content of those notes as well, to sort of see whether there are different types of words being used when we talk to families with maybe different medical literacy or other biases that we may have.
Yeah, that's really interesting, and it strikes me it's sort of in some ways a distillation of what everyone in society needs, which is like an advocate at their bedside, right? Like we all need someone to help speak for us when we can't speak, and that's really what you've been spending a lot of time doing, working on in the last few years. So very neat. I'm wondering. So you had mentioned this kind of early work you had done and then kind of losing yourself in I think what we all do, which is this kind of external expectation of what it means maybe to be an academic neurointensivist, and then finding yourself around 2018. And the cultural climate has been changing rapidly. And maybe in 2018 into 2020, this work in DEI was starting to get appreciated and even popular. And we're seeing lots of papers and healthcare disparities, and people are starting to move. Well, what do we do beyond just documenting disparities? And then all of a sudden, in the last few years, it seems like this work is rapidly losing popularity. In fact, it's even at risk. I'm wondering if you can comment a little bit on kind of how you're feeling about now having taken on this mantle. How are you responding to this sort of climate change that we're facing?
Yeah, that's a great question, Nick. I think that on the one hand, I think that because there was so much energy and enthusiasm around it, it gave voice to a lot of people, and there's a lot of people in the space, and that was great. I mean, I really think that I haven't seen that sort of collective attention on a problem for a long time, and so it really felt like we were galvanized and we were moving forward, and how quickly it feels like the axe has come down on these efforts, and how swiftly and how fast. Um, and it's a very tough moment. Um, I think that I'm really concerned that the people who might not have been in it for the right reasons, like, easily left. It's easier to leave the effort now because there isn't the support and there aren't the resources, and we have to take this work on again. But the thing that I think a lot of people found is that this is what makes life worth living. This is what makes your academic work worth doing. Um, and so, one of the things that I think was pretty amazing for me personally was really actually getting involved. I know this is going to sound sort of hokey and a shameless plug, but I mean, finding like-minded people within NCS really was sort of a safe haven. And I think that's actually what's keeping me doing the work too, is just knowing that there are amazing people doing amazing work out there. And even if I don't see it in my local space, the fact that I can actually keep in touch with it across the country, across the countries, internationally, it feels more doable, even in the setting that it's not getting the support and it's being actively sort of reversed. I feel like I have a broader network now of people who are like-minded and who really want to push this forward. But I also feel like the stakes have never been higher. So it's never been more worthwhile to do this work. And so yeah, I think that that's sort of where I'm at right now.
Yeah, and the stakes are high for our patients too. What do we know about disparities in healthcare and particularly within neurocritical care?
Um, so, I think that it's interesting to see the evolution. Like obviously there are a lot of disparities. Even in the like early 2000s, people were talking about disparities and outcomes in terms of who's getting a cardiac cath, who's getting a PCI. We know that gender disparities occur, and how do women present with stroke or heart attacks versus how men present. But there wasn't necessarily a lot of action tied to the disparities. It was like we recognized it, and then what? Um, I think that you know it's it's actually a little sad. Like the National Academy of Medicine in like 2003 published unequal treatment and recognized that there were inequities of care. And so not only were these inequities systemic, so like access to care and things like that, but it was actually even on the part of the providers that we are that our inherent biases impacted how we delivered care, and that these were actually associated with poor outcomes. In neurocritical care specifically, I think that it's really interesting to me to see. We know that stroke outcomes differ by race. Black Americans who have strokes nearly have twice the mortality than white Americans do. We know that in TBI outcomes, the CDC has reported that outcomes vary by race. So if you're an American Indian or Alaskan Native, your outcomes are particularly worse after a TBI. And that's from everything from acute treatment to rehab to cognitive therapies after, which is pretty demoralizing, I think. It's really hard to recognize that. And so I think, but like once it's brought to your attention, then I think you can make change. And so one of the things that I'm feeling a little more optimistically about is that obviously in intracerebral hemorrhage, there's a lot of effort now on new treatments, and it's really sort of an exciting time. But the AHA is also recognizing that looking at race the way we've looked at race is not necessarily the right way. We're using a social construct to diagnose a genetic and biological process, and those things don't mesh. And so it may be more important to think about like the way the JNC8 taught me to treat hypertension is actually antiquated and old, and there's never been proof about how why we give or why we used to treat hypertension with certain medications for certain races, that none of that was ever borne in any actual study, and it was all sort of theorized but not actually true. And that there are now efforts afoot to really say, okay, well, let's look at the run-in access. Let's look at actually treating patients not according to race, but including people from all racial categories into research so that we can study this the right way. So, I think that in my mind, like stroke and TBI are probably some of the biggest diseases that we treat in neurocritical care. And I think that they're easy starting places.
Absolutely. You mentioned these inherent or implicit biases, right? The kinds of biases that all of us have, that we have even sometimes without recognizing that we have them, and that affect our behavior. At least at University of Maryland, where I work, and I'm guessing at University of Pennsylvania, where you work, this has come to light, and institutions have brought about a series of implicit bias training courses. What do we know how these courses actually affect disparities? Are they improving things?
To be honest, I don't know the data on how well they're working or not working. I do think that it's offering a language around recognition, though. I think self reflection should be paired with sort of a debrief and review of action. One of the things that we're doing at Penn that I'm really excited about is sort of is interdisciplinary simulation to really talk through events as they happen, so that we can feel comfortable saying to one another, "Hey, I'm not sure that that was received in the way you intended it." And so, really trying to think through calling each other out when there are issues that are coming up that might indicate inherent bias or implicit bias, and creating an atmosphere in which every member of the team feels like they can offer their perspective and viewpoint on how a patient interaction goes. I think we really have to leave these hierarchical, paradigms aside and move towards the collective, because I love it when the patient and their families really feel that the med student understands their needs, because that means that we're meeting that person's needs. That's all that matters. And so
Mhm.
making sure that those types of things are incorporated into the way we practice and deliver medicine, I think is critical.
Yeah, I love that. We do interprofessional simulations as well, and we work a lot of our programs off the AHRQ's Team Steps program, and
Mhm.
recognizing this need for kind of stepping in when there's behavioral malpractice, I call it, in
Yeah,
non-punitive ways, to sort of check people and recognize that this hierarchy, which is built on not just what profession you are, but there's all these other things baked into that, right? Which are racial, and sociocultural, and economic, and historical, and that when we're rude as the attending physician, to kind of, as we punch down sometimes, or sometimes when we punch up, if we will, that it's not just what's happening between those two individuals, but it's really kind of representing some larger forces at play that everyone kind of gets, and then it has a much larger impact than we think it does, doesn't it?
absolutely. I think it sort of permits bad behavior. It sort of kind of extends bad behavior, and it really limits voice. I mean, we were talking before about using your voice to make change, and it really quashes any other types of voice, or I'm not going to disagree, I'm not going to put myself in that position. And so it really squelches any different opinion or viewpoint. And I think upstander training is something that we should really be focusing a lot more on. I find it even very hard for myself to call things out in the moment. And so, but I'm becoming much more confident in doing
Hmm.
that. And I really think that that actually is a skill that can be imparted easily to everybody. And that's why I love the team steps, and I love, giving everybody language to say, hold on, I'm not comfortable with this, or I'm
Yeah.
concerned about this. I think it really does help to sort of pause, take a time out, and say, let me just make sure I understand this right, because I don't want this to become the culture of our institution or our unit or our team. Um, so I think that it's critical.
That's great. I'm glad to hear you all are incorporating that at your
Yeah.
institution too. That speaks to my heart. Maybe we can kind of change
We'll do another
topics.
podcast on
Yeah, yeah,
sim
yeah.
and
And it's just
HRO
another way
principles.
that we can use simulation, right? That a lot of people
Yeah.
don't really
Yeah.
consider. Um, but let's sort of move the focus back to, you gave this really wonderful keynote speech at NCS last year that helped, I think, a lot of people connect some dots that maybe they hadn't connected before, in the way that really, quite frankly, political action affects us at the bedside in neurocritical care. And I'm wondering, maybe we can go through a few of those political actions and talk about kind of what their ramifications are for us as neurointensivists, and to take a role from our trauma, or a line from our trauma colleagues. Where is our lane, right? That we've heard this, stay in your lanes type of rhetoric. So the first one you talked about was really affirmative action, I think, and the Students for Fair Admissions versus Harvard College and UNC. And can you tell us a little bit about, some people might think, well, that's for schools, right? We're undergraduate education. Why does this affect what I do in terms of taking care of patients in the neuro ICU?
Sure. So I think we have to start by saying that diversity actually does improve outcomes. Because if you don't believe that, then it's not going to make sense, I think, kind of how this is unfolding. But we actually know that diversity improves healthcare outcomes. It actually improves outcomes in nearly everything. And that's really because it minimizes groupthink. And so it brings cognitive diversity to the table. And so when you have cognitive diversity, really you're opening up to more possibilities and really can lead you down the right road. And so it's been shown in finance, it's been shown in the research labs, and it's been shown in education that really that diversity improves outcomes in every discipline, and medicine is no different. We also know that affirmative action improves diversity. And we know this because different states have actually had affirmative action bans over the course of the last couple decades. And so, most notably, California actually instituted a ban of affirmative action in 1996. And one of the things that we can study is that what happened before the ban and what happened after the ban. And it was very clear before the ban, there was a lot more diversity, and not just diversity of African Americans, but diversity with Latinx people, AIAN people. There was just a lot more diversity across the board. And then after the ban, within 2 years, it was actually very quick. The number of Latinx students in particular dropped precipitously.
Wow.
It was like a 40% drop at the UC schools. And they were actually able to look at the cohort of people who comprised that drop. And like they could see like those people would have gone to this school. You know, they didn't get into UC Berkeley, they didn't get into UCLA. So where did they go and what did they do? And it's like a pretty linear relationship between not getting into those schools, getting, doing like having fewer job opportunities and not getting sort of the long-term compensation that they would have gotten and if they had gotten into, these other schools. And so, I think it's very clear to say that if you don't get into one of those schools in the undergraduate level, you're not going to get to the graduate level, and then you're not going to get into these competitive professional jobs. And so I think that's the relationship between diversity and specifically medicine or medical school. Now, in terms of what the cases were, so the Students for Fair Action versus Harvard, which is a private college, and the same SFFA and UNC, which is a public university, they took those cases on at the same time because it basically looked at undergraduate admissions in those two areas. And what they basically said was that that the precedent that had been set of affirmative action was overruled. And they said it's because in the case of Harvard, Asian students were discriminated against because they said that even though they had higher test scores and higher extracurricular activities, they rated less as a group. And so that was used as a stereotype, which is part of the Equal Protection Clause. It's not allowed to be used as a stereotype. And then at UNC, they were saying that it was about a white student who didn't get into the undergraduate class in 2014, that he had been discriminated against because students who had from underrepresented groups had a higher standing in the admissions process. And so those were the two companion cases that overturned affirmative action in the undergraduate setting.
Great. And so this obviously is a threat, as you said, to enrollments in professional schools and really who's becoming a doctor and who's working at the bedside. And what do we know about, does it matter whether we have a diverse workforce as physicians in the neuro ICU and how well we represent our patients?
Yeah, it actually really does. And there are, data looking at if you have a diverse physician work group. So for example, there was a study done, I just published last year, that looked at the number of Black family care providers or family practitioners in certain counties. And they looked at from 2000, like just epochs in time. So 2009, 2014, and like 2019. And when they looked at the number of providers over that time, they also looked at life expectancy of Black people in those counties. And just by having providers in their counties that shared their racial makeup, their life expectancy went up If you have the state of Florida looked at nearly 2 million births, and if the race of the infant or the neonate was the same as the race of the provider, their mortality was halved. That's pretty remarkable, and I mean, I think if we all thought to ourselves, like if we could see ourselves in our patients, or if we feel some kinship with their family, some dynamic, I think we all know it's a human nature to sort of give a little more and try a little harder. And so, whether that explains all of the disparity, I don't think so, but I definitely think that that's part of it. And so, even West Point, in terms of the military, they feel that it's very important for the leadership in the military to mirror the troops. Because if you're going to defend your country, you need to know that everybody has skin in the game. And so I think it's really critical that that's how healthcare is for sure.
Yeah, and yet recently we've had House representatives who are really claiming the opposite, that patients are getting inferior care because we have a more diverse workforce who has quote unquote taken advantage of these affirmative action roles to get to positions that they don't belong, when that's completely against what all of the data really support. But this is really a threat. And maybe, if you don't mind, could you talk a little bit more about this Educate Act and this idea that medical schools are really being compromised and maybe having to get rid of their DEI offices or any other similar type of equivalent. And this seems to me to be one of the biggest calls to action of our time. What are your thoughts?
I couldn't agree with you more, and I'm outraged at even the title of this act. So the Educate Act stands for Embracing Anti-Discrimination, Unbiased Curricula, and Advancing Truth in Education, which to me is hypocrisy at its finest. When the act is working to dismantle EDI efforts in higher education, it is outrageous. And it's just a shameless, I think it's pretty
really
shameless,
subversive,
to absolutely just, and confuse people. I mean, I think they really are trying to sow confusion because people don't know what these things are about. And so if the Educate Act was on your ballot, you might think that sounds like a good thing. And so, I think subversive really is the term. But I think they know it because the evidence is clear, that diversity in healthcare improves patient outcomes. And so, I think this is just a naked attempt to maintain the status quo, to keep those in power. It's how people in power keep power. And this is not something new in our country. I mean, we've been working to take money away from people as they gain it appropriately. We've worked to take land away from African Americans. We've worked systematically to decrease loans for people who live in certain areas so that they couldn't advance. I mean, this is just the same in present day.
What are some pragmatic steps that maybe some of the listeners can carry forward to try to combat what's going on right now on this front?
Okay, Nick, well, why don't you ask the hard questions?
That's why we invited you.
I think this is it. This is the $1 million question. Some considerations, I think, you're right. I mean, we have to actually talk about what can we do, because what's the point of just lamenting the situation we're in if we're not going to make we're not going to take action. So one of the things that we're doing at Penn is we're not like, our pathway programs aren't about race. They're about distance traveled. Did your parents go to college? If your parents did go to college and you're going to be the first one to go to college, hey, that's a huge accomplishment right there. And so maybe using that as a criteria, maybe using geography. What is your zip code? Instead of favoring the people who come from the zip codes that have more resources, maybe you look at applicants who come from zip codes, and it's not about race, it's about zip code. So I think some of those things are really important.
Now, for the
Employing
listeners, right,
holistic,
I'm sorry, for the listeners, you're
so
referring basically to this idea of the area deprivation index. So we can, this is widely available information that we can look up based on zip code and see basically what are the opportunities for people that live in this area.
absolutely. And it's actually, the ADI is really, it's so granular. It gets down to the US Census defined block. So you can look at, because I know in Philadelphia, and I suspect in Baltimore, one block this way, one block that way, and it can be a very different sort of situation. And so sometimes zip code is too big
Yep.
an area, but you can actually use the area deprivation index that I think Dr. Amy Kind from the University of Wisconsin actually created a beautiful map, and she has actually color coded it to make it more kind of visually clear that these are the areas that have the highest resource, and these are the areas that have the lowest. And they take in information from everything from schools to access to food and groceries, to parks and things like that, and really kind of come up with an understanding of our country. And what you can see is that, like, on the coasts, there's a lot more blue, which is coded for higher, increased affluence and increased wealth, not just monetary wealth, but resource wealth. And then in more of the central part of the country and in the South, you see more of the crimson, which is, where there's fewer resources. And coupled with this is access to healthcare, right? I mean, we know about the, urban rural divide as well. And so we're sort of depleted in certain parts of our country. And it's critically important that we find a way, using, it's a little more creative than using race as, which is sort of an easy mark. But to be honest, I think we have to admit that, sometimes race wasn't the right measure. Sometimes, if you're from a high socioeconomic status and you have a lot of resources, race might not be the best marker. Although acknowledging that
It's
people,
pretty robust.
it's pretty robust, and even people
Yep.
from, if your skin is black or dark, it doesn't, you're not, or even if you have money in your pocket, you're not protected from the ills of racism. So, I think that one thing that we can do is really to think differently for pathway programs, like how we can, bring, the resources to people who could use them most. I think it's important to employ a holistic review, look at people in the totality and not try to strip them down to a couple different factors about themselves. I think that that doesn't tell the whole story. Utilizing standard rubrics for interviews and for promotion and other leadership opportunities. This is really critical because this is where the implicit bias comes in. This is oh, my gut instinct is that person is the right person or the right fit. When if you look at them, and see, well, how many papers have they written, or, what are their teaching scores or things like that, you can start to get a fuller picture and a more equitable assessment of each candidate against the other, and then you can make a more educated decision about who to choose and how.
Yeah, I really worry about, we're going through our fellowship applicants probably as you are right now. And when we sit, together as a group, and every once in a while you hear the line, "Oh, I think they'd fit in really well here." I always, that I used to say that, and now it kind of makes this, the hair on my back and the neck stand up, because I'm not sure what that means. And to me, it almost feels like a red flag that we're going somewhere we shouldn't be going. Because maybe, as you said, if diversity really leads to better outcomes, maybe we don't want someone who fits in.
Exactly. I think, who's going to bring us something new? Who's going to bring us some, a different way of looking at things that might be the most innovative? I think that fit sort of thing, all it does is just narrow your scope. It doesn't, broaden your horizons. And I think that's really the most critical, to meeting our patients' needs where they are, meeting our trainees' needs to where they are, meeting our staff's needs where they are. I mean, I think so many things benefit from the diversity that different perspectives bring and different people bring.
Yeah.
I think the other things that we can do is we can really work to retain our faculty. So one of my kind of newer roles is that I'm chairing a society for clinician scientists at Penn because we learned that there's a lot of early attrition of clinician scientists here, and we're trying to figure out why that is. And our vice dean for faculty has really tried expertly to put numbers on these things and to interview people and figure out, why are you leaving? Where are you going? Some amount of attrition, is good. Hey, they're taking a better position somewhere else because we've helped make them successful. But when they're leaving within a year, within a couple years, it makes you think, whoa, maybe we're
Mhm.
not meeting them where they are. Maybe they think they're supposed to be doing something, even though they're meeting their metrics. Maybe someone's making them feel that they don't belong. And if that's the case, then we need to fix those problems. So that's sort of my new passion project for right now. Um, and also, I think thinking about it's not just so there's what are things that you can do? You could do term limits, right? Like, has your division chief been division chief for as long as you can remember?
Mhm.
Well, maybe we need to change that. Maybe we need to give other people opportunity to be in those leadership roles, to think differently about leadership, to change how it's done. And then they have the skill set to then, continue to advance. I think, again, it's one of those things where leadership is sort of in the hands of a few. We know this for gender, even though more women make up med student groups than men. When it comes to leadership down the road, you don't see as many women leaders in those same roles, and why? And the same thing goes for URM on a much grander scale. So how do we keep that from happening? Well, things like term limits can actually offer solutions that are practical and pragmatic. I also think about like your research lab. Diversifying your research lab might be something that you can do on the local level. Editorial boards. A lot of the editorial boards, they all look very similar. And so having more diverse opinions and diverse voices, might actually allow for different types of scholarship to be published with the same attention to detail. And, we'll put in a shameless plug for NCS, but, the more people that come from that look different, that act different, that think differently, that join together in a medical societies can also change the tenor, and the attentions, right? I mean, medical societies get to define what things they take on in the same way the people who make those decisions, and that's medical societies, national societies, your home institutions, universities, all of those things. The priorities get defined by the people in charge. And if these are our priorities, then we need to ascend to those ranks so that we can be a part of making those decisions.
Yeah. Well, you do have the hard answers to hard questions, it turns out. So I think those were that's a whole list of things that seem actually achievable, although hard to do. I would also put in a plug for NCS. I'm always amazed at how similar kind of people look at NCS. And if people are listening to this podcast who think maybe I don't belong there, well, we have a home for you. It's the Inclusion Neurocritical Care Committee in the hopefully section, and we welcome you. All right.
Absolutely.
Let's we're coming up on time here, and I want to get to a couple other things. So we're going to move on. Um, your keynote, you also described this really interesting connection, I thought, between Dobbs v. Jackson and then ultimately the UDDA revision and talking about brain death. And again, this is something where I think a lot of people had never thought that these things in any way could be connected, and yet you made these connections. So what does one have to do with the other?
Um, so this is just so exciting for me. So thank you for letting me talk about this. I think at the heart of Dobbs v. Jackson, the unspoken question is, when does life begin? And so the reason that many of the states are choosing 6-week bans is because that's the time at which the heartbeat is observed in embryonic development. And so if the heartbeat is what many people are using to define life, then the heartbeat may be what is used to define death. And as a neurointensivist, that's not always true, right? We have death by neurologic criteria as defined by the UDDA. And so it gives me pause. Like, what if we can't do brain death determination anymore? What are the implications of that? So, one, I think that, you know, it is a very confusing state for a lot of people. And so if we lose the legal ability to define death by neurologic criteria, well, then we may be increasing the number of patients in our healthcare system who we would have defined as dead. I mean, that we don't have medical treatments for, and that we don't think, you know, will improve. And so that sort of takes that away. And then also, we do define brain death, and then patients or families have the option to pursue organ donation. And if we don't have brain death, then the number of organs goes down. And so last year, there were 100,000 people on the transplant waiting list, and 40,000 organs were transplanted. So not everybody who needed an organ got an organ. And that worries me. There's already been disparities in the organ allocation process. How do you define who needs an organ more than another person? And some of those decisions were sort of opaque to the public for a long time. And there have been efforts to really make that more equitable. But again, that was an area where there was significant and inherent inequity. It's also, these diseases aren't equitable. 4 times as many African Americans have kidney failure than white Americans, but more organs get transplanted for white Americans than Black Americans. So there's inequity. There's also the type of organ transplanted. More living donor organs go to white Americans than Black Americans. And so why is that a problem? Well, the outcomes are better for living organ donors or living organs that were donated than from the dead donors. And so, that keeps me up at night. That makes me worry. Like, how are we going to meet the needs of patients who need organs for transplantation if we lose the definition of death by neurologic criteria? And it actually, I think we've all in recent past, we know that there's a lot of confusion in the lay press about like what is brain death, and so with that confusion, normally you would say like just take a time out and make sure everybody's on the same page, but we really can't afford to do that because people's lives are in the balance. So how do we update the UDDA in a seamless way? Well, in this current political moment, it's proving to be too difficult. The United Law Commission, or the ULC, who writes the UDDA, they're lawyers. They're not doctors. They're informed by a panel of colleagues of ours, among others, but they're not doctors themselves. And so I read in Nature last year, this was really concerning, that one of the commissioners of the ULC was around in the 1980s when the UDDA was first drafted, and he was a proponent of death by neurologic criteria, but now he's actually decided that he's not, and his day job is to work for a pro-life organization in DC, and so I think he's making the connections between access to abortion and brain death, and so that's very worrisome.
Yeah, well, thank you for bringing that point forward. And I think I'm one of those people hadn't really considered this that deeply, the connections between these two issues. But I think you're right, they're real, and we need to deal with them. And I'm also worried. You mentioned that the UDDA revision is on pause or hiatus, and I think Ariane Lewis has written about this recently in the most recent journal in neurocritical care, and she talked a little bit about how the first iteration really describes the determination is left up to best medical standards. And I think a lot of us are worried, and I think she hinted at it in her article, that there's been a politicization of what are medical standards. And this is affecting everything from brain death to gender affirming care to a host of other areas. And it's really, really worrisome.
I totally agree. And I think, even to continue this, the comparison between, access to abortion, which is now, because there are no federal protections, are defined by the states. Um, the UDDA is a federal protection, but it's still defined locally by the states, and that's what's causing a lot of the confusion, because you can be dead in
Yeah.
one state and not dead in another. And so part of the reason that we want the UDDA to be updated is to give that federal level of standardization that it can do. And yet, we're seeing that play out with the abortion debate, and how, you can't get an abortion in one state, but you can get an abortion in another state. It's causing a lot of confusion among providers who are at those state borders. What can they do? And it's reducing access for people even within a state that's legal, because you get a lot more getting patients from across the border. And so, again, I feel like it is sowing discord among, the populace. And so everyone is confused. Nobody knows what is right. Even like all the well-meaning people, are trying their best, but you don't want to be on the wrong side of the law. No one is advocating that, but, that's happening. So I know, even for me, the Penn Forum for Women Faculty, that is now a
Mm.
group that is coming under fire, because can you just be for a gender? And so we have to be thinking about these things. And I know, part of the reason I went into medicine, I felt like it was a straighter path, and I'm pretty risk averse. I don't like being in legal jeopardy for doing my job,
Right.
and talk about moral distress and burnout, right? Like, I want to do what's right for my patients, but I can't, because I don't, like, the government won't let me. I think, I don't know if I ever told you this, but I matched in obstetrics. My intent was actually to do this work with my life, and I just fell in love with the pesky brain. Um, but I think that I had never been put in a professional capacity to think to myself, like, do I do the work that I know is right, and take the consequences? Whereas a lot of my, OB colleagues have been wrestling with that
Hmm.
decision for a long time. But here, we absolutely are going to be dealing with it. And, I think in my talk last summer, we had a patient who came in, and I had to think to myself, like, what do I do first? She was 30 weeks pregnant, twin gestation, had a massive cerebellar hemorrhage, with, I think, only a couple brainstem reflexes. And, it made us all stop and think, oh my God, how are we going to manage these situations that are very, very complex? And, it, you know, and that, to me, is a recipe for increased moral distress and burnout. Like, when we can't do the things that we know how to do because of systemic barriers, um, that really, it's unacceptable, and it makes a lot of people want to leave the job they were called to do, and that just can't happen. We can't let that happen.
I completely agree. We've covered a lot of ground, I think. Um, yeah, I'm just curious because it has been a while since your talk, which was last August, and the news cycle continues. What, what else is keeping you up at night these days? What else that we haven't talked about are you worried about or should be on our radar?
I mean, I would say that the Educate Act is one really
Yeah.
has me troubled. You know, I've had sort of the amazing fortune of being able to give this talk over the last year, at about, I don't know, 8 or 10 institutions, and each time I give the talk, I add a little something. And I was thinking about how Claudia Golden, who is a labor economist at Harvard, She won the Nobel Prize, and then her work is really about women in the workforce. And she credits the birth control pill with really propelling women in the workforce in a way that nothing else could have done. And I can't help but think to myself, like, well, if access to abortion is restricted, these issues with in vitro fertilization are now being called into question, then women aren't going to be able to plan their careers um, on their own time. And that's going to take women out of the workforce in significant numbers. And we already know that we don't have enough nurses. We don't have enough advanced practice providers. We don't have enough physicians, 54% of whom in medical school are women. What is this going to do to healthcare? And what are the implications of that for, healthcare outcomes for all? I think we talked a little bit about diversity and its impact on healthcare. If we don't have gender diversity either, then I think we won't be meeting patients, needs well at all. And I could go on. I think there's
Yeah.
so many. And this is not even like climate change and affirming, gender affirming care. And I have so many personal, very deep seated feelings about a lot of these things. And I don't know how I can function through a day without just outrage. I am going to say that I do think that the newer generation of physicians, nurses, trainees, I think they do an amazing job at really thinking critically about this. I think they value these conversations.
Mm-hmm.
I think they're thinking about things differently than we did. I think they're questioning the status quo more. So I have hope and I do have faith. But I also think that like hope and faith are not enough because they are not active processes. We need to do. I have to say, if people hadn't heard Alistair Martin's Inc. keynote from a couple of years ago, find him. I mean, he's easily found on Instagram and all sorts of places. But the impact of voting on these specific issues cannot be understated or overstated. It is critically important that we recognize, and I mean, even to the point of this educate. I mean, if you go into the voting booth and you don't know what you're voting on and you see that, you might think to yourself, oh yeah, that's something I go for.
Yeah.
So being a concerned citizen who takes their responsibilities, their civic responsibilities seriously, I think that is really an important part. And I think that I'm spending more of my personal time figuring out how I can be a responsible citizen in a way that I just never have before. And if you find yourself in the Philadelphia airport at any time in the next year, check out this store called 1920s Merch. I mean, it is merchandising around, but it's around the women's right to vote that they got in 1920. And it outlines in pictorial form around the store the 50 years preceding a woman's right to vote. And, it's for all the people who've said, history repeats itself. It really does. And I think that there's a lot that we can learn from history. And so, I think just informing yourself is arming yourself. And I think that that's really where we need to go.
Okay, well, I love that. So let's end it there. Thank you so much for joining us. I learned a lot today, and I learned so much from your talk. And I hope maybe you'll come back on the podcast again in the future to talk about some of the many other things that keep you up at night and keep all of us up at night and raging through the day.
If you'll have me, Nick, I'll come back for sure.
Yeah, and I also just want to thank you for being a strong advocate for the Inclusion Neurocritical Care Committee, and before that, the Women in Neurocritical Care Committee, who I think owe a lot to you, and for representing the larger group, both within our society and beyond. So thanks so much.
Thank you, Nick. It's been a lot of fun.
All right. You have been listening to the Neurocritical Care Society podcast. This podcast is available anywhere you get your podcast. Please like and subscribe. And continuing education credits are available for select episodes. Thanks, and check us out again.